it is very hard to get them to really sort of talk about these, even when they're through the acute episodes or they're older. I've had some kiddos with pandas that are much better now, and I've been working with them for years. And also, a lot of them don't remember. They don't remember now when it's over, which is a blessing. But the compulsions are any action that's done to reduce that tension. And these are much easier to identify because they're the actions. So it's the hand washing for the germ phobia, the avoidance of a certain family member. And you'll see that a lot. There'll be kind of an identified target in the family. It could be a sibling, it could be the father, it could be for whatever reason. And that person is contaminated or germy, and they'll avoid that person. Rituals, routines, counting, checking, things having to be done in just the right order. You see a lot of gait anomalies, so crossing thresholds for whatever reason can be very difficult. You'll see kids sort of, go to the door and they start and they stop and they've got to go through it just right or perfectly symmetrical, or there'll be a lot of tapping and touching as they go through the door when they're having an acute episode. And the other one is restricted food intake, not related to anorexia. There's no fear of getting fat. There's no body dysmorphia. These kids don't know how many calories are in an apple or in a salad. Any kiddo who has an eating disorder could tell you right away how long they have to exercise to burn off whatever they had for lunch. It's related to the OCD or the sensory issues. It's the fear of choking, vomiting, germs, contamination. I've had lots of kids where if they couldn't unseal it, like a pudding pack, and take one bite with a spoon that they got shrink wrapped, one bite, throw it away, it's already contaminated. It could be the sensory issues. I know a family where they have to drive around to different fast food restaurants to get a straw that somehow is right, is not contaminated, go to 8 different places. And we'll kind of touch a little bit on that too, about how families will go to extremes to try to get their little person to eat. But then there's a point, of course, where we have to educate the family and pull back from that. Okay, so it can present lots of different ways. You'll have those 2 cardinal symptoms, and one thing that's important to remember is that there is this sudden, dramatic, overnight onset, and within a couple days. If it's been over a week and more gradual, I still say we owe it to them to at least try to address it this way, because in psychiatry, a lot of the neuropsychiatric symptoms we see with pandas and pans, once those are set or permanent, they can be very refractory to treatment, particularly OCD and issues with food and eating. So sometimes I've noticed that people get sort of hung up that it wasn't this overnight thunderclap, which we do see. Lots of the kiddos I see, there were these little prodromal flares where there's a stepwise increase with each episode where they don't return to their baseline. And so each time there's an infection with strep or mycoplasma or Coxsackie or Lyme's or whatever, there's a worsening, but there's usually a family story that accounts for it. Well, that's the year we moved. That's the year Grandpa died. That's the year Fluffy died. And so we kind of have a way of explaining that. But when you really take a careful history, you can start to see, well, that's when so-and-so had pneumonia. Another family member had pneumonia, or they were sick all the time, and they had chronic ear infections. You'll see they got ear tubes around that same time. So family history is really, really important. You can see anger, irritability, isolation, depression, a lot of regression. We'll see a return to baby talk, playing with toys much younger, playing with younger kids, lots of separation anxiety. Lots of these kids want to sleep with their parents again. Incredible separation anxiety. I've had kids that would not leave the couch. They were literally on their parents' lap and would not even stand up. They were that anxious about it. Academic decline is very common, particularly we see math go first. We'll see a lot of sort of cognitive clouding. They describe feeling slow, that their brain just isn't putting things together. It's harder for them to write an essay, harder for them to read and understand and retain things. I've had a couple of patients where throughout the year, we will see MAPS testing scores. And because I see a lot of kids for a long time, one thing I find very valuable is if they keep an assignment notebook. It's ideal because my notes are all dated and time-stamped. I know when they had strep throat or a mycoplasma infection or whatever, and we can correlate that worsening handwriting, which is dramatic. I know Dr. Sweeto showed some examples right there with our clinical notes and infections. And so we've also sometimes seen over the years, you know, MAPS testing. We'll see a kid go from 98th, 99th percentile, or whatever they call it around here. Every school calls it something different, but it's that standardized testing they do. Some schools call it STAR testing, the WKCEs, whatever. But we can really see this dramatic, like they'll go from 99th, 98th percentile, and then in the fall of the following year, boom, we're way down to like 68th percentile. It's just dramatic. Sensory or motor, this we see with the handwriting, but also there's a decline in the fine and gross motor skills. We see that with the handwriting. They get really clumsy. Some of them are just falling all over. Increased sensitivity to textures, tastes, fabrics. I will see kiddos all the time in the winter wearing flip-flops. They cannot get that pair of socks that feel right. They will, oh my gosh, getting them dressed in the morning, very tough. And then of course, sleep and the enuresis, the nocturnal and diurnal, the rate at which some of these kids have accidents during the day. And I know Dr. Sweeto touched on this, but the theory of the mechanism behind it is because they do lose that control of their internal anal sphincter, no, urethral sphincter, and the control of holding in their urine is related only now to the external sphincter, which is under our control. You know, we don't, it's not an involuntary, it's under our more conscious control. And so they have to sort of hold that in, and the rate at which like they'll have overflow or they'll have accidents suddenly goes up. And I've seen that happen in kids, you know, 12, 13 years old. And so that's definitely something that it should set off alarm bells. So I'm going to start with a patient of mine. Of course, her name is not really Claire. She's a 10-year-old Caucasian female, and her parents came to see me as a referral from their primary care doctor because they thought she had PANS. So Claire's history, going back over time, there was some low-level waxing and waning stuff going on, concerns about food, wanting to eat healthy, a little bit of worry about contamination for several years, but it was never clinically significant. It never posed a problem. She could eat with everybody in the family. So they noticed a significant and dramatic increase in her symptoms in October of 2017. So it became much more significant. So when I first met her, there was this increased worry and rumination that her food had been contaminated, that there was something in the food that was going to hurt her or kill her or react in a certain way. I've had other patients where they kind of develop a delusional belief that these foods they eat could somehow combine in a way that could harm them or kill them. I had a patient who developed a belief that if he ate foods from different cultures, so if he had hummus with Korean barbecue, that the two would combine in a way that would be harmful. And so he had developed these interesting, as we say, logically illogical ways of eating that somehow he felt were safer. So it was actually the following month that she had some allergy testing that just showed a mild, localized allergic reaction, possibly for certain types of nuts. And this just, you know, we were off to the races. She just ruminated excessively on how things were going to contaminate her, hurt her, kill her. So this, within about a week and a half to 2 weeks, she had lost 7 pounds, and her BMI is now down to 14. She's, you know, really very, very serious, and this is all consuming. Her, you know, how Dr. Sweeto had mentioned, you know, we're looking at, you know, about an hour a day kind of gets you the diagnosis of OCD. So an hour a day spent ruminating with the thoughts or the negative images, and then of course the compulsions, which are the things they do to make themselves feel better. If you spend about an hour a day doing that, that'll get you the diagnosis. This was all consuming. She couldn't go to school. She couldn't really do much else, and just could not eat. Her, I have a couple notes here. In addition to that, she could not eat if her mother was not around. That her mother had to be with her at all times, and the only way to get her to go to school was for her mother to be at the school over the lunch hour. And so her fear was that if something were to accidentally get in her food, even though she knew her reaction to these nuts was just like a little mouth irritation, and it was localized, not systemic, it's not the sort of allergy that's going to kill her. She had an EpiPen just in case, that she just really had developed this fear. So her mom had to be there. Her mom had to prepare her food. Her mom, nobody else could touch her food. If anybody even got near her food, she wouldn't eat it. And this would all start all over. So in addition, she had to touch everything in a certain way, and we'll see that too. There's just a lot of rituals with touching and tapping and counting. For example, the evening ritual had become quite extensive. It would take hours to get her to go to bed. She had to have the same amount of kisses from her mother each time on each cheek. It had to be symmetrical. She would wash her ponytail holder 8 times before she would put it in her hair. Little things like this that can really be very disruptive. She would get very angry for no reason, or I'm sure there was a reason, we just didn't always know what it was. She was just consumed by thoughts of dying and death and what-if scenarios. Lots of reassurance seeking. We will see that. Kids that are needing reassurance all the time. And they're never reassured. You could tell them 1,000 times, you could show them information, you know. If you could take them to their doctor, their nurse practitioner, their PA, they would explain the medicine. Doesn't matter. They're still worried. Let's see. So then her, as we talk about with this OCD, how it is logically illogical, when she went to school, she would collect sorts of bits of things of, you know, trash and odd things she would find on the playground and store them in her pockets, which again is sort of interesting for somebody who has contamination and a germ phobia. And so that's, you know, just, it doesn't mean it extends to everything. The germ phobia, I'm a big proponent of like therapeutic riding. I have a horse myself. We go to the barn. A lot of my patients, I tell about the barn because there's a therapeutic riding program there. They can be at the barn, you know, but they have OCD and compulsive hand washing, but it's not at the barn. So it doesn't mean it's not there. It just, this is how OCD presents. It's very illogical. So let's see if there's anything else. So you know, for psychiatry, we always document a mental status exam. What was really, you know, sort of interesting about her, obviously she's underweight. She's incredibly anxious. We kind of describe some of that as very guarded, anxious, scanning, watchful. So that's sort of the kid that sits there and they're sort of scanning their environment for things that could harm them, and very, very still and stiff. Would not separate from her mother, literally just glued to her mother. So, we see here, and we already covered that. I put these up not to bore you to tears, but to kind of talk about, these are some rating scales that I use. I use many more, but these are the ones that just give you an idea of how severe her anxiety was. I have the actual scales up here if you want to look at them and see what they ask about. But so the first one just is a scale for generalized anxiety disorder. It's 7 questions. I like it because I can do it in the office in about 2 minutes. And it's very reliable. And it's also kind of nice to repeat them and to see if what we're doing is working. Sometimes, and this is no fault of the families or anything, I mean, there's a lot going on in their lives. I have kids myself. I mean, you don't know, you know, from month to month, it's kind of hard to remember where you were and where you are now. So it is sort of helpful to say, well, you know, we started that Lou box, you know, she was like an 18 on the GAD, and her Y box was 40, which is the top, and now we know we're at, and then like, oh yeah, that's right, because they will kind of forget over time. So the Y box Yale Brown OCD scale, 30 is really severe. The Psi box, I think Dr. Sweeter also mentioned this one too, so here's the Yale Brown OCD scale, and here is the Psi box is the Yale Brown OCD symptom checklist. And the two work well together. You can take a look at the questions they ask about. But basically, what I do is I have the kids fill these out first, because this is pretty much a list of just about any OCD symptom you could have. And a lot of the kids do find this reassuring when they see how many they don't have, or they see, oh boy, you know, I guess things aren't quite so bad. Other people have these too. And then all you do is you check out if you have it currently, if you have it any time in the past. It could be both, it could be none. And it gives you a good idea of what sorts of things that are happening without the kids having to verbalize that to you, because it does talk a little bit about the negative, recurrent, intrusive thoughts and images. So once they do this, it sort of helps to bring to mind the things that they're dealing with. And then this one, the Yale-Brown OCD scale, it simply breaks it into the obsessions and the compulsions, and it asks them about how much time they spend on those during the day. And you get a total score. So hers are pretty severe. So the SCARED is another rating scale I really like. There's a parent version and a kid version, and it just screens for lots of anxiety disorders. So the SCARED self version, she was positive for pretty much everything except one thing. Her parents' version, yeah, she was positive for everything. So that's also kind of nice to see in terms of if they agree. If there's a huge discrepancy between those scales, that can sometimes mean something else is going on. Okay, medical history, multiple strep infections, pattern of increasing anxiety, OCD. She has tonsillar stones, which I hadn't really seen much before, and they're pretty significant. Her dad has them as well. On exam, her tonsils were 2+ bilaterally, but her throat looked normal. UA negative, immunizations up to date. I know Dr. Sweeto talked about this for the, let's just make sure we don't miss this. And, if you're anything like me, I know polymigratory joint complaints, chorea, erythema nodosum, and erythema migrans, which is, of course, the classic presentation of a Lyme's rash. That's not going to stick in my head. So I like these little pictures. And so just sort of to think about, okay, if you see a combination, sore throat, skin sores, swollen joints, hey, start to think about checking for a heart murmur. I just included pictures, so the erythema nodosum, that usually is front of the legs, under the knee, leaves some bruising and discoloration after it's healed, because it's really only around a couple weeks. And then, of course, the erythema migrans, which is the classic bullseye rash, but it can actually present other ways too. So there's some nice little pictures. So I wanted to take a minute and talk a little bit about inflammation, because a little test that I find to be very, very valuable is the ibuprofen test dose, which I don't know if any of you have ever heard of or tried. But really what we want to do is minimize inflammation. And I could talk with you about inflammation for a week. But essentially, we want to reduce things that contribute to the release of these inflammatory cytokines. And that would be by keeping allergies at bay. I do allergy testing, just the classic, whatever the American Academy of Allergy, Asthma, and Immunology tells me to check for region 7. Asthma, make sure that it's extremely well controlled. We'll treat allergies year-round, minimize infections, look for underlying autoimmune conditions. So the ibuprofen test dose, strong, fast-acting, anti-inflammatory. We dose it 3 times a day. It's generally safe and well tolerated, even though most parents are a little nervous about giving ibuprofen 3 times a day. I've not had an issue with it. And really what we're looking for is, does it help the symptoms? Ibuprofen does not treat OCD. It won't make a difference in a kiddo who just has sort of a classic obsessive compulsive disorder presentation, which is kind of rare in early childhood. But I do have a paper here if you're interested in looking at it that sort of compares the two. What does classic non-PANDAS PANS related OCD look like versus the type we see with PANDAS and PANS. So she took 400 milligrams 3 times a day for 2 days. But then, of course, life happens, school schedule. So she had to go down to 400 milligrams twice a day just because it was hard for them to get that 3rd dose in. And her mom was like, that made a difference. That was a big difference. And that, now I know we are on the right path because, again, ibuprofen does not treat OCD. I included this simply because, well, these are some of the labs I checked. There's some more often too, and believe me, I'm not going to waste your time by going over all of them. I did want to point out a couple important ones. So first of all, at the top, if you have the right code, you can save your families a lot of money by just checking the right box, because then insurance will cover it. So you can kind of see the examples: autoimmune encephalitis, screen for endocrine disorder, unspecified disorder of immune system, blah, blah, blah. So I included that just in case you found that to be helpful because, you know, by trial and error, I've sort of found those are the most valuable ones. The ones that I would want to highlight that are the most important are, of course, the ASO anti-DNase antibody and throat culture. And don't forget to try to culture the rest of the family. That's important. And then also, I take a look at the vaccine titers. I want to know if they responded to their vaccines. That can be a huge hint that there's an underlying immunodeficiency, particularly because checking the immunoglobulins just above it, that can get pretty expensive. And so I don't really look much further into it unless I kind of have that hint, and I'll get to that a little bit more in the future. I always check B12, folate, and D. Every kid with pandas has low D. Every kid. I've never seen a kid.
Everybody in Wisconsin does.
We are in Wisconsin. A lot of us are Caucasian, so we're going to have low D. And what I have seen too, even with repeated prescriptions during 50,000 IU, 90,000 IU per week for months, I've had these kids that the D is just low. And there's an interesting study. I was talking with Dr. Sweeto yesterday about how they're actually going to publish something soon. I think Kyle, who used to work with her at the NIMH, he's now at Harvard, is publishing really interesting findings on vitamin D, whereas, you know, that the symptoms go down as the D goes up. And I've seen that clinically in my practice all the time. B12 and folate, really important cofactors, obviously, for folate synthesis, depression, and all that, but we won't get into all that today. I didn't miss anything. Oh, mycoplasma. I always check mycoplasma, IgM, confirm it if it's positive with EIA, and then of course IgG2 mycoplasma is a big one that causes a lot of the same symptoms of pandas and pans. Here are her labs. Pretty darn normal. D was low normal, fine. I like it in the 40s to 50s if I can get it there. And okay, so great. She's super healthy. What do we do now? Okay, begin augmentin. Why? We don't really have an identified target. So the reason I started augmentin on her is that she has had in the past a strong positive response in terms of OCD symptoms to amoxicillin. Kind of learned that from the family history and as we trace everything out. And she responded to the ibuprofen test dose. And so we're going to start augmentin. I'll talk again a little bit about augmentin in a minute because I think Dr. Sweeto also touched on it, that combination of amoxicillin with the clavulanic acid has been really helpful for a lot of our kids with pandas. We swabbed her family, and then I wanted to look into some additional labs such as the allergy testing, her complement system, the vaccine response, and of course then we put in the referral for CBT. So augmentin, the clavulanic acid readily crosses the blood-brain barrier, and I think as a lot of you know, that antibodies themselves, the antibodies against strep pyogenes, which is the primary culprit that causes pandas, they express this factor, so these Th17 cells, which allows them to get through the blood-brain barrier, track back along the olfactory nerve, hang out in the olfactory bulb, and then cause the damage they do by that molecular mimicry process by which they think parts of the brain, the caudate and tamen, are actually strep. And that's where we see a lot of that inflammation coming from. So the clavulanic acid also, though, has anxiolytic and antidepressant properties itself, so that can be very helpful. Azithromycin is a wonderful anti-inflammatory. Reduces lots of inflammatory cytokines. So on top of inhibiting bacterial protein synthesis, I was pretty surprised to see, even after a good course of antibiotics for people who had like a mycoplasma pneumoniae, finishing all their medicine, there is still an issue with that mycoplasma being able to avoid and evade the immune system and kind of hang out in the body and hide. So that one is, azithromycin is a good one, and you got to really treat hard. And then don't forget the probiotics, they're wonderful. Really reduce any risk you would have, to have problems with being on antibiotics for a month is what they are recommending now. So antibiotic prophylaxis. I just wanted to talk about, this is an article that Dr. Sweeto had a slide up for yesterday. How many of us were here yesterday too? I don't want to repeat myself. Oh my gosh, okay, good. You're all going to probably remember a couple of these slides, but this is the one, it's 2005, it's an old one but a good one, but really showed some good data on the benefit of antibiotic prophylaxis. So they took a look at the year before with these kiddos, I think there was 23, and then the year during the study when they were on prophylaxis. So this one I really like. This is the same article I'm referring to, but you can see these little, oh, I could use my pointer. These little explosions here, these are strep infections. And then that's the SIBOX, the Yale-Brown OCD symptom checklist. So you see how there's this clear spike in the OCD after, yeah, you can all see it down there too, after a strep infection. This was the year prior to the study. And then the year on the study, they didn't have strep, which was nice. That was actually a finding in the study that the kiddos didn't get a strep infection. And also, you can see there is not that associated increase in the OCD. So that was nice. And then Dr. Sweeto had this one up yesterday, so I won't spend too much time, but essentially over on the left side is the year prior to the study. The right side is on the penicillin prophylaxis, and those purple lines are showing you the flares and the intensity of the flares. So you can see there's a dramatic change after the prophylaxis. Okay, so my girl, significant positive response to the augmentin, and so I saw her 20 days later, but I was also in touch with her mom over the phone, and this is what her mom said. So the nighttime was better. It used to take hours to get her to go to sleep. Constant reassurance seeking. Mom had shared with me that even after she had fallen asleep and her mom had fallen asleep, this little girl would go into her mom's room and wake her up and kind of start asking the questions over and over again about, am I going to die, am I healthy, am I going to get this disease? Then after starting the augmentin, her mom said it was like 1 or 2 questions and then she went to bed. Now I know Dr. Sweeto also talked a little bit about sleep, that REM sleep disorder, disrupted sleep. And that is a common finding in kids who are struggling with pandas, and pandas take some hours to fall asleep, and their sleep is very fitful. And so what was nice here is that she just went to bed like no big deal. What I was really happy about is that she was starting to eat again. She had lots of ideas about food and when she could eat, when she couldn't eat. Mom had to be there. She actually let her brother take chips from her bag of chips that she opened, clean. That was pretty amazing. She has a favorite restaurant that when this was really flaring, she loves this restaurant, but she couldn't let herself go. She couldn't eat there. Well, she could go, but she just couldn't allow herself to eat there over fears of contamination, especially because she couldn't be assured that whoever was in the kitchen did the right job. So she would go to this restaurant, and then other people would eat, and that she liked to go with them because at least she could smell the food, but she couldn't let herself eat, which to me kind of sounds like torture. But she was able to eat breakfast at that restaurant the day before I saw her, and then go right to school without her mother. And then the day I did see her, she ate breakfast at that restaurant again, and even brought me the little containers, to show me, which was nice. It was nice to see her being able to get back to her normal life. A lot of the rituals had settled down. And this is where we sort of started talking about now how to help the family start to back off. We hadn't yet had our first CBT appointment, but talking with them about how you don't want to be an enabler, and now it's time, her mom actually had been able to go to the lunch briefly at school and then start to leave. We sort of just talked about how we're gonna, move that out. That'll be our goal. So, let's see here, her vaccine response. So, she didn't respond to tetanus at all, and that's a protein-based vaccine, and indicates, it could possibly indicate a subclass deficiency. So tetanus is, the response to tetanus is mediated by IgG subclass 1 and 3. She did respond to pneumococcal. So with pneumococcal, really if you read, it'll say, oh, okay, kind of want you to respond to 70% or more of the serotypes. I always check the 23 serotype because that one includes both pure polysaccharide, our body's ability to see it and mount an immune response, as well as a polysaccharide complex with a protein. And so she did, 70% is ideal, 50%, that's pretty good. And if you talk to the immunologist, they will tell you they really just need 5. If the rest of their immune system is intact, 5, and they're going to be fine. So she had 13, fine, that's good. Hib, she's indeterminate. So if you respond to Hib, again, so Hib is a protein and a polysaccharide, indicates subclass 2 and 4. If you're under 0.15, we know you're not covered. If you're above 1, we know you're covered. Well, she's a 0.5. So that's something we could take a look at in the future in terms of revaccination. She didn't need to be revaccinated because she was getting her tetanus, another tetanus that summer anyway. So we'll just follow up on that. So of course then the question comes about, well, what if it didn't work? What if the augmentin wasn't helpful? Now what do we do? Okay, well, you know, you could think about steroids, sort of a low dose versus a burst and taper. Other anti-inflammatories, this, so turmeric there's good data for. N-acetylcysteine, good data for. Really, where I had been familiar with MAC, which is also called inositol, is in the trichotillomania studies. Trichotillomania is really, really hard to treat. And there's some fairly good data with high dose MAC. It goes up to about 8 grams a day. And I've had families where, because it's a supplement, it's over the counter, anecdotally they'll come in and say they started it. I had a little girl, her OCD responded beautifully, just 400 milligrams a day. And then there's just, bromelain and quercetin, there's some pretty good data with those too. Then it's like, now you're in the Wild West, there's all sorts of supplements. You will learn about a new one every single day, many times a day. Those are some I see. I've had no luck with low dose naltrexone, and neither is Dr. Sweeto. I checked with her just to see if. And then there's some of the references if you wanted to look into them more. Okay, questions? Because I know some of you have to leave in a little bit, you know, to get on service by 9, but, and I know I went fast.
I have a question. So, explain the rationale for treating when there's no laboratory proof.
I brought my little library with me here. There's a nice little report. So, you know, Dr. Kiki Chan, he is a big pandas pans researcher. And if you like, I can get you a copy of this. But this sort of goes over why treating, even if we can't identify an infectious etiology. So clearly, if you have, if you've swabbed their throat and it's negative, and you know that that there's no current or acute infection there, lots of people are saying, well, why on earth would you then give an antibiotic? Well, we have a couple of interesting situations that come out. So in terms of enlarged tonsils and adenoids, they can be a repository for strep that doesn't always show up on a throat culture. So when you take a look at, first of all, rapid strep is fairly worthless. If it's positive, great. If it's not, to me that really doesn't mean much. You've got to have the culture. But when you take a look at actual clinical practice of people doing throat cultures, and I know Dr. Sweeto says that story with Dr. Murphy, about if you haven't drawn blood, you haven't cultured aggressively enough, it can be pretty hard to standardize that in the community. They actually miss quite a few. So we could be missing them. Number two is that there can be these occult infections. There are kiddos who are chronically colonized. It could be a perianal strep, it could be a vaginal strep, where a throat culture is just not going to pick it up. So we see that, and then we see kids who are carriers. Now what will also happen is that, and I have a patient right now I just saw a few days ago, where his strep has never been positive. We've never had a positive strep on him. His sister has celiac disease and some other autoimmune issues. Every time she gets strep, he flares. And we know this because this has actually been also reported in the literature. There's a point where, and well, now I'm going to lose all of you because my husband promised me I wouldn't show this, but basically when you take a look at the T cells, okay, now I know everybody's asleep, but the T cells. So when you think about our immune system and how, you know, when with these inflammatory cytokines, oh, I can just hear him laughing at me, and I'm going to try and address this in a minute or two, that, you know, once you start to go into this PANDAS or PANS process, it begets a more and more autoimmune state. And so, you know, we have our naive T cells, our Th1 cells, our Th2 cells, And they can kind of go into, either a regulatory profile or an inflammatory profile. And when we have these inflammatory cytokines, that pushes them more towards a pro-inflammation pathway, which means now there's even more of this TNF-alpha, interleukin-6, interferon gamma, blah, blah, blah. But what that does is that then it further sort of pushes this cascade into more and more autoimmune conditions. So we sort of know, if you have a person that has, say, autoimmune thyroid disease, they're, if you take like a female, okay, well, they're more likely then to develop polycystic ovarian syndrome, or insulin resistance, or anovulatory cycling, and now possibly moving into a diabetes. So when you get autoimmune conditions, they have a way of sort of continuing. So when that happens, and when our bodies are more sensitized to this autoimmune response, this exaggerated immune response, where it makes so many antibodies to other things, even if it's not strep, they don't have strep themselves, but they're simply exposed to it, we will see a flare. So by treating them prophylactically, number one, you cover for, is it possible it was missed? And in some community studies, as much as 30% were, just by poor swabbing. And there really is like that little tick over the back of the throat, you're not going to get it. And it is tough. Nobody wants to see kids gagging, but number two, you, for at least that next month, prevent them from additional exposures or a new exposure. And you would get rid of, if there was this chronic colonization, it could be perianal strep, vaginal strep, whatever. Throw away the toothbrushes, swab the family, and then really throw away those toothbrushes like every week for the month you're treating. And then if it isn't helpful, then you've at least tried it. That's sort of where I go from there. It's really not that hard to be on antibiotics for a month. There's lots of liquids, there's chewables, generally well tolerated. And so that's where I go with sort of that. There's actually lots of reasons to at least try. I hope I answered that question. Oh, yeah.
Yeah, for those of us in primary care, the demographics would say that a good number of these cases or patients with some of these symptoms will fall off the algorithm. In other words, they probably don't have this. And can you give us any examples from your practice how you dealt with the patient and the family where they fell off the algorithm? In other words, it was apparent to you that they probably didn't fall into this and need any further treatment or evaluation?
Yeah, that tends to be highly anxious families anyway.
Right.
Yeah. A lot of education. I think, yeah, right now I'm being flooded with these certain families now that are coming back to me, but they, I agree with you, that can be really delicate because there's a resistance to accepting that. And the important thing that I point out too is that, grandma's anxious, mom is anxious, dad has panic disorder or whatever, and sort of talking about how, if like the ibuprofen test dose, it's not going to be like, oh, maybe it helped, maybe it didn't. No, you got to notice it. If you didn't notice it, if it wasn't apparent to everybody, then it didn't help. And so that's kind of where I start that conversation, because I actually have them do that, and I draw a lot of labs before our first appointment, because that gets us so much farther than when we actually do sit down and start talking. So if there isn't a lot on the ibuprofen test dose, if the labs are all coming back, stone cold negative, I kind of approach it as that this is really good news. This is a healthy young person. I haven't been able to identify any potential underlying immune issue where we might need an immunologist. However, we're gonna go really slowly. We're gonna sort of think about what supports we can put in at school. I'd like us to start thinking about treating some of this. This is distressing. Clearly, he's anxious. He's depressed. He's whatever. Some of those folks are resistant to more traditional psychiatric interventions, and that's kind of a bias. They tend to want to be more natural and have supplements, and even though I can't really point to any FDA data or randomized controlled trials on that, but hey, you could try a little sertraline, which has been around forever and is really safe. So it's kind of an ongoing conversation a lot of reassurance. I don't know if that answers your question too much, but yeah, there are some kids that just don't have it. Yeah.
So we've talked a little bit about augmentin, we've talked about Zithromax, Dr. Sudo had mentioned Septinir, the cephalosporins. Where in the continuum of those choices will be your first?
If it's strep, augmentin. If it's mycoplasma, azithromycin. I get a lot of records, and I can go back, we compile a lot of data before we ever even see our patients. And so I will go back and see. And so, for example, one I just saw a few days ago had been on Septinir for about a month, and nobody really thought it did much. And then they, right there in the history, they said, you know, he was on a Z-Pak, and oh my God, that made a difference. I thought, okay, we're gonna go with azithromycin. So I kind of looked to the family history, I looked to if there's been a positive response to anything in the past, or what sorts of bugs were there. But really, I don't think you would go wrong either way. Septinir is usually third for me.
Are you doing like standard dosing then at that point?
No,
Whether it's
no.
augmentin or you're going high dosing?
Yeah, augmentin I go high dose, 60 mg per
Same
kilogram
thing
BID.
with Zithromax, so you stick in with the.
Yeah, Zithromax I do.
One steady dose per day, same
So
dose.
the way so with mycoplasma, and because mycoplasma is such a dirty little bug, I treat that pretty aggressively. So if they're, you know, above where, so if their weight is fine for the maximum daily dose, I do 500 milligrams a day, and I do that for 2 weeks. And then what I say to the family is, you know, my default is to do it for a month if it's well tolerated. So I have families call me back a lot because I can't always get them in as fast as I want to, but I want to keep this moving along. So I'll say to them after the 2 weeks, well, first of all, are they any better? They should be. If they're not, we've got to kind of go back and relook at things. After the 2 weeks, I'll say, okay, I want you to go down to 250 a day. But if we lose anything in terms of coverage, if we see the enuresis come back, the wetting, the food restriction, go right back up to the 500, we'll run it out for the full month, then we'll try again. And so with each time I'm trying to step down, the default is if we lose any of that nice improvement we had, we go right back up. And then you step down to 250 3 times a week, then 250 twice a week, then off, is sort of how I do it. Then if we have, though, had some pretty significant flares, I have not been able to find anybody to do plasmapheresis. I definitely have had some kids I was worried sick about. I've got lots of families that have flown to California, DC, at great expense because these kids were gonna die. I mean, they were not eating. We were tube feeding, they're at Children's. In Milwaukee, unfortunately, doesn't really have an understanding of hand-as-or-pans, and so those families really had to go somewhere else for the rituximab or plasmapheresis.
How do you feel about doing like dual medications at the same time? Doing the antibiotic at the same time as you're doing the anti-inflammatory?
Yeah, oh yeah, for sure.
You know, are you looking at like which one is going to be the thing that's going to fix?
Well, the ibuprofen test dose I usually have them do prior to the intake, because I'm going to want to know that. So I already have that data, and then I'll even continue it. I mean, especially because by the time they get to me, these are not mild symptoms. You know, so okay, the risk of being on ibuprofen 2 or 3 times a day for a couple weeks until I can get you in is pretty low compared to what we're dealing with. So hold that, because I never want to lose anything. If we've gotten some improvement, we don't want to lose that because these things are additive. So then if we see an infection, we'll treat it right away, kind of look at the history, make a decision about if we're going to start an antibiotic or not. We're going to go to steroids, look at allergy testing. Allergies contribute significantly to these flares. So I don't know if that sort of addresses it, but yeah, and then we'll also add in an SSRI. I mean, we're just trying to get this kid functional and sort of figure it out, and then figure out what in the immune system potentially led to this.
I'm just thinking like the idea of multiple modalities working all at the same time. How do you discern like which was the thing that actually worked?
Because they're added in stepwise. Yeah.
That's what I was asking.
Yeah, they're added in stepwise. Though what will happen is that your families will be on the internet and they'll be trying all sorts of things you don't even know about. So that's why I'm always asking what herbals, what supplements, what, you know. So that is a little tricky, but most of them will tell you, and they'll bring in, you know, the sheets that explain what they're on. But yeah, it's a stepwise approach. Yeah.
I would think that you know, if you have a child in a or a child who's compulsive about contamination, and then you in fact tell them that yes, your problems were due to contamination with the bacteria, that it would be, you know, almost guaranteed that afterwards they would still have some worries or fears about this. And so I would think that it says you would consider the cognitive therapy, but I would think that would be almost always needed, no?
Refer to cognitive behavioral therapy.
Okay.
Yeah, I hope I didn't say consider. But no,
So
that's like
the
referral.
flow sheet-
Refer
the flow sheet
to
says that.
the what sheet?
It says consider the algorithm.
Oh,
So
yeah.
I would think it would just be required.
Oh, yeah, yeah.
Okay.
Well, they don't want to go. I've never had a kid ever want to go, ever. Once they go, it's helpful.
Yeah.
And then they see that, but gosh, they hate exposure and response prevention work. So if it is something which oh gosh, they hate it. And they have to be at the place to do it too, though, because if they are, you know, really like Dr. Studio says, if their brain is on fire, they will not be able to process it. They're just way too like brainstem and amygdala. But yeah, once we kind of calm things down, it's a great idea. Yeah, no, I'm very pro CBT.
Okay.
Yeah, any other questions? Or cases you've seen? Yeah.
If there was exposure to ticks and
Yeah.
presented with a rash, Lyme was negative, would you test for other tick-borne illnesses too?
There are some, yes, there are a couple others. You're kind of getting into the weeds there though a bit. So if there was a tick and it looked like a deer tick, it was tiny.
It was tick endemic, visit to a Lyme endemic area.
Sure.
Came home with a rash and developed the behaviors.
And how soon after that did you check? I would recheck.
Lyme was checked, I think, immediately, and then 3 and 6 months later.
And always negative. Maybe try a little doxycycline if you were worried about it. But that's very interesting. I screen everybody for Lyme's, and I had 2 active Lyme's just this past year with kids with sudden onset pandas and PANS. So I would try. What's the harm? You know, if you thought that. There, a lot of the stuff with pandas and PANS, you know, like Dr. Frankovich talks about this discomfort. You know, there's a lot of pain and joint pain and early fatigue that sure could look like Lyme's. You know, cognitive clouding, you know, that goes along with Lyme's too. Yeah, I guess I'm sorry that it's been a while, it sounds like, since that initial one, but I've had adult patients who have had a lot of interesting issues that I've checked for Lyme's and they are positive. I don't even know how long they would have had it. And I sent them to an infectious disease specialist because I'm certainly not going to try and address that. And they had remarkable and dramatic improvement after some, you know, a more aggressive treatment for Lyme's. So I guess I would just maybe see a specialist and talk with them about it. I mean, some may poo-poo you, but yeah, that's too bad though, especially if they were in an endemic area. The other thing I would do is look at their immune system. I've had some kiddos whose immune system was so down they couldn't mount a real vaccine response. They couldn't mount a real immune response, so we weren't able to see antibodies being made against it, but it was still there. That's at that point I would refer to immunology or infectious disease. But yeah, that's a tricky one. But of course, a doxycycline never hurt anybody. I had a bite once that I thought looked like the erythema migrans. I'm like, I am not even messing with this. I am just going to call in some doxycycline for myself. So, any other questions? All right. Well, thank you all very much.